to Mr. Elnekave. Yeah, okay. He's talking about endovascular molecular targeting of mesenchymal tumors. So quite another type of tumors today. Examples of novel therapies for enigmatic diseases, and it's really a rare disease, and there is a lot of treatment burden with these tumors, and we'll see if in Tel Aviv this can be reduced. Thank you very much.
Great, thanks for being here. This is going to be a short introduction or talk about endovascular treatments and molecular targeting of mesenchymal tumors. So mesenchymal tumors, otherwise known as soft tissue tumors, are broad spectrum, and the tissue types associated are really connective tissue cells. So it can be fat cells, lipomas. Most of these tumors are benign entities. So fat cells, fibroblasts, neural sheath cells, endothelial cells, and muscle cells. But more specifically, we'll talk about fibrous tumors. These are tumors that involve a hyperactivity or proliferation of fibroblasts. And the span is from very benign entities like keloid superficial scars, palmar fibromatosis, to the most malignant manifestation, which would be a fibrosarcoma. And the fibrosarcomas will metastasize, the others will not. And as opposed to other types of cell malignant progression, there really is no progression from these different types of tumors. So the locally aggressive category, which would include deep desmoid fibromas and inflammatory myofibroblastic tumors, or solitary malignant fibrous tumors, will, even though they are locally aggressive and can be quite infiltrative and have significant morbidity and even mortality, they won't progress to be metastatic. So let's look at this group for a second. It's quite an enigmatic group because the fibroblasts have a close relationship with immune cells. They're stimulated by immune cells to produce extracellular matrix, and this in a normal physiologic environment is conducive to scar formation, and it's essential for repair. But the process can go unregulated, which is what you see in such manifestations as desmoid fibromatosis and some of the other conditions like IgG4-related sclerosing disease and, again, malignant fibrous tumors. Now, the etiology is very poorly understood. There are some conditions, some syndromes which are related to fibromatosis, but the vast majority are sporadic, and similarly, the treatment armamentarium is very diverse. So this includes steroids to target the immune cells. You can have B-cell depleting agents, immunomodulators, tyrosine kinase inhibitors, radiation therapy, cytotoxic chemotherapy, as well as surgery. Now, I'll just briefly talk about the concept of surgery in these situations. So there's a risk. You're dealing with fibroblasts which are naturally inclined to produce extracellular matrix and scar, and they are stimulated by a surgical environment. That's what they're sort of born for. So if you have a chance to get an R0 resection and really remove every last cell, go for it. But any minimal residual tumor left behind won't just be a positive margin and a source of recurrence. The recurrence is generally much more aggressive and infiltrative. So if you have a sleeping dragon and then you resect and you leave a few cells behind, you run a risk of much more aggressive disease. I'm going to just show so how do we treat these? The idea of an endovascular approach is that you don't actually elicit the sort of response immunogenically that you would through surgically. And I'm going to show three conceptual examples, I think 4 cases, of how you would use endovascular treatment to either facilitate surgery or to obviate the need for surgery in relatively extreme examples. So this one is a retroperitoneal fibrous tumor in a 26-year-old woman. And what you can see here, where's the pointer? So what you'll see here is a normal appearing right side. normal appearing right side of the body. This is a normal kidney, a normal liver. This is the spine. On the left side, a massive retroperitoneal tumor, which is invading the spinal cord and essentially suffocating that sick appearing left kidney. When we do a catheter-directed injection of contrast into the vascular system here, you'll see a preferential flow of blood to the left. And what we're seeing here are two phenomena. So you see a neovascularization, which is degeneration of new blood vessels to the tumors. And you see the tumor, we call it a tumor blush, but essentially it's a visual manifestation of the EPR effect. You see enhanced permeability and retention of contrast in the tumor tissue itself. Now, the problem with surgery in these settings is that they're very vascular tumors. The perioperative morbidity is very high, and the chance of getting a complete resection is almost impossible when you have so much blood flying through this tumor, because with any bleeding, you have seeding of the peritoneum of tumor cells. So the idea here is to identify the blood vessels that are supplying the tumor and then selectively catheterize them and close them off, in this case using a liquid embolic agent or glue. We used onyx. So just briefly, this is an L2 embolization. You can see the tumor blush before and then essentially stasis. You can see the small branch of the tumor blood vessels, which are occluded by the material. Here we have the left kidney vessel and then a branch of it. This is the capsular branch, which is supplying the tumor, and then a selective catheterization of that, again blocking the blood flow from that origin. Moving on to L3, same concept. And then when we get into the pelvis, moving from the right side of the pelvic to the left side of the pelvis, this is the posterior division of the internal iliac artery, and we see most of the muscular branches. This is the gluteal muscles. We see a solitary branch here from the iliolumbar branch, which is supplying some of the tumor, so we can navigate and then basically embolize just that portion, avoiding any injury to the either pelvic viscera or to the musculature of the thigh. What you see here is a follow-up angiogram. So again, this is flow of contrast in the same distribution. We no longer see blood flowing to the tumor. We actually see some blood going to the right side of the body, including the right kidney. And then this is a follow-up image post-operatively where the tumor has been resected successfully, including that left kidney and several vertebral bodies. But the operation, which was 12 hours, required 2 units of blood and achieving an adequate resection. So now that we understand how we can use blood vessels to get to tumors, the next concept here is how can we use blood vessels to get therapy into tumors. So here we're using 75 micron beads. These are, I know this is very big in this community, but for us it's considered very small. And we're giving doses of approximately 50 to 75 milligrams of doxorubicin, which are loaded onto these resin beads. So this is a child with a huge axillary desmoid fibroma. You can see here that the fibroma is very invasive. It's essentially compressing the thoracic wall on the right. Here we have a selective catheterization of the axillary artery. We see very large hypertrophied vessels, including an acromial branch here, which is actually, this is a deltoid branch of the thoracoacromial artery. We selectively embolized or delivered particles with this chemotherapy agent into these branches, and over the course of, so what we achieve is basically a 50-fold increase amount of drug into the target, with virtually zero systemic drug, which is useful, especially in doxorubicin, because it's cardiotoxic, especially in a child of this age with this amount of tumor, it would be prohibitive. And over the course of a year and 4 treatments, we achieved almost a complete resolution of this tumor. So 97% reduction in size, no more symptoms, and the chest wall has re-expanded in the lung with it. Another similar example would be a gluteal fibroma in a 16-year-old woman. Here we have a sagittal view, so her face would be looking that way. This is the sacrum, and above the sacrum, the tumor. This is an axial, so from lying down position, and we see on the right side, this is the tumor. And when we catheterize here from the left groin up into the right, we are now injecting contrast into the internal iliac artery on the right. This over here is the superior gluteal artery, and we see a selective catheterization here, just opacifying the superior gluteal artery. Looking at it from the side, you'll see that, again, the sacrum, This is the S1, S2 bones of the sacrum, and this is the superior gluteal artery, which we would expect to traverse this course and supply the tumor. Once we've catheterized that and selectively injected contrast, we can do a CT on the table to show that, in fact, we see the contrast arriving from this single vessel and then beginning to opacify that tumor with almost no other extratumoral supply. We feel safe. We can treat from this position, a little bit of material in the lumbar muscle. But after the course of only 2 treatments, this is 9 months apart, we've achieved over a 90% decrease in size of this lesion. So no surgery and no other treatment in this case, just a local delivery of doxorubicin. Another case would be of a 20-year-old woman with a fibrous IgG4-related sclerosing disease. It's an instructive case for a few reasons. When she presented initially, she had quite a large but a benign-appearing tumor. So these are both T2-weighted MRI images. We see an iso-intense T2 signal in a large, bulky lesion in the left lower lobe, which is pushing the heart anteriorly, but not invading it. The surgery was debulking, so removing most of the tumor, but the little that was left behind, really this represents this idea of the sleeping dragon to a very dangerous dragon, because now it's not pushing the heart, it's actually invading into the myocardium of the left ventricle. You can see a thin rim of left ventricular myocardium, and T2 hyperintense signal corresponding to the tumor. The idea next is to identify the blood supply to this tumor. So I'm going to just delineate the cardiac silhouette, and behind it you see this rhomboid-shaped mass in white. So this is the actual tumor on a chest X-ray. And what you'll see here is catheterization from the intercostal artery on the left, the 7th intercostal, just underneath the 7th rib, and injection of contrast, and you see really this EPR effect. This is a visual manifestation of the EPR effect. The contrast which is getting in, the tumor knows how to create parasitized blood flow, but it doesn't have the ability to create the lymphatics and venous outflow. And so you see the rhomboid appearance of the tumor here. We also catheterize the left coronary and the right coronary arteries, and the same tumor blush is arising from the right. So our first approach was to deliver 270 milligrams of doxorubicin selectively into these arteries and of SoluMedrol. So now we're giving a relatively low dose but a high concentration with hope of a first pass effect. And as we saw a response, which was modest, and we were happy with it, but we sought a less invasive and more bioavailable drug delivery approach. This was where we found our collaborators in Hebrew University to work with us and provide a liposomal formulation of SoluMedrol, which has the advantage of being more bioavailable, having more stability, and the ability to deliver the dose in a less aggressive way intravenously. So this is the formulation here. And we'll see that, again, this is the pre-op image, this is the post-operative image, and really she went through about 1.5 years of multiple therapies, including methotrexate and SoluMedrol intravenously to the point of developing toxicity with cataracts. And by the time we got involved, there were really very few, or if any, systemic options. But when we look at her now after 2 different therapeutic approaches, and she's still in treatment, we see a significant reduction in the size of this lesion and regrowth of that myocardium, kind of buffering the effect. So we're still treating her, but interim results as of March 2017, we can see that here. So the idea here is that the goal that I see is the combination of anatomic and molecular targeting. So I think of our service as interventional radiologists or interventional oncologists being really a UPS service. We can deliver a package to a house, but we really don't have the ability to make sure the right person opens it. And here we have to make sure that it's addressed to the right cell population. And this is where we need you. But a lot of what we're hearing today, if it involves tumor stromal environment and so forth, there will be similar environments, whether it's fibrous tissue or an EPR effect from inflammation in the knee and other places of the body. And the challenge I put forth to this community is how do we combine the 2 therapies so that we can leverage the EPR effect, leverage drugs that address a particular microenvironment, but do it in a local way so that you increase efficacy and also safety. So with that, I'd like to thank you and thank our collaborators both at Children's Hospital Schneider and at Hebrew University in Jerusalem.
So there's one question.
Very nice talk with a real life experience I've never heard here. My question goes to the last part where you showed that after the resection, when the some part of the tumor was left, that started invading into heart and started growing there. So could you find, like, was the tumor cells or fibroblast or which was invading? Because I can understand the fibroblast have very well properties compared to muscular cells like.
Yeah, absolutely. So in fact, these particular tumors have a low Ki67. So if you look at the mitotic fields there's a low mitotic activity. It's not so much a proliferation of fibroblasts, but the ability for them to create more fibrous tissue in a higher pressure environment that lets them move forward, and also to utilize and actually increases their ability to generate inflow of blood. We see this in other tumors as well. I mean, really, even for colon cancer, you don't operate on patients who have metastatic disease because the actual surgery can be tumorigenic. The combination of an initial inflammatory response and a secondary wound healing response works to the tumor's advantage because as you have lymphocytes infiltrating tumor tissue, you have tumor cells getting back out into the bloodstream with the permeability with the enhanced permeability of the endothelial cells. And then when they lodge somewhere new, with the systemic healing that happens post-surgically, they have the ability to recruit more blood and actually generate an environment from the cells. In this case, we just know that because of the natural stimulation of fibroblasts, which is a response to wounds, when you create a wound, you are stimulating them even further.
Thank you very much. Are there further questions? If that's not the case, I want to close the session. Thank all the speakers and all the participants asking questions.